Hi, I'm Colleen Campbell and I'm part of the UCSD ultrasound team, and today we're going to talk about pelvic ultrasound. And below you see my beautiful dog Butterfly. So the first thing we're going to talk about is an overview of pelvic ultrasound. Ultrasound is extremely sensitive for pelvic pathology. If you use pelvic ultrasound, you never will have to do another bimanual examination. The best way to learn pelvic ultrasound is to incorporate this into your pelvic exam very early on in your practice. To get credentialed, you need 25 transabdominal and 25 transvaginal scans before you graduate. When you do the FAST exam on females, you can turn your marker dot up and view the uterus and also get credit for transabdominal ultrasounds in this method. First, we're going to go over the uterine anatomy. We will be able to see the vaginal stripe on transabdominal ultrasound, followed by the cervix, the uterine cavity, and the fundus of the uterus. We will be able to tell if the uterus is anteroverted or retroverted. We will be able to see the ovaries, but not necessarily the tubes, and the relationship of the ovaries 1 centimeter anterior and 1 centimeter medial to the internal iliac vein and artery. We will be able to differentiate the endometrium from the myometrium in the uterine cavity as well. So ultrasound planes are a little bit different than other planes that we use in ultrasound. The transvaginal scanning, we use coronal when our marker dot is to the right, and sagittal is when our marker dot is up. So the left side of the screen will represent anterior structures. Here again is planes of pelvic ultrasound and where we would place our marker dot. Transverse, we would place our marker dot to the right. A long view on the abdomen would be if we place our marker dot towards the head, and this would be the same for transvaginal scanning. For the coronal view, we will place our marker dot to the patient's right. For the abdominal exam, we want a full bladder to provide us an acoustic window for our ultrasound. This will give us a wide view of the pelvis, and this is always recommended to start here with the pelvic ultrasound. This is an example of a transabdominal transverse view of the uterus using a phased array probe, and what we see here is a uterus floating in free fluid, and you can actually see the ligaments suspending the uterus in this view. Whenever we see a floating uterus, we know that we have a lot of intra-abdominal and pelvic free fluid, and this is abnormal. This is a sagittal view, transabdominal, of the uterus, and what we see here is vaginal stripe. We can follow that to the bulb of the cervix with its Nabothean cysts, and then we can follow the endometrial stripe out to the fundus of the uterus. We see anterior to this is the bladder. Posterior, we actually see a small amount of free fluid right here. In this view, we have a transabdominal view of free fluid in the pelvis. And what we see here is bladder wall. And then anterior to that, we see free fluid. Below that and deep to that, we see the vaginal stripe, the cervix, and the fundus of the uterus. So we know that this uterus is anteroverted. This is a good viewing of the pouch of Douglas right in here. We see free fluid, and then where we see that is right behind the cervix, and these are large Nabothean cysts in the cervix. Here again, we see free fluid anterior to the uterus as well. Let's talk a little bit more about the uterus and the ovaries. The endometrium of the uterus is darkest early in the cycle. It thickens to 10 millimeters through ovulation. and 85% of the time it is anteroverted and anteroflexed. The ovaries are 2.5 to 5 centimeters by 1.5 to 3 centimeters by 0.6 to 1.5 centimeters. The dominant follicle may be up to 2 centimeters. Physiologically, we may see a small amount of free fluid around ovulation or menstruation. This is a transverse transabdominal view of the uterus and where we would find the ovaries near the uterus. And we would find them by following out the corneal flare of the uterus here and training our eye for a hypoechoic space compared to the surrounding bowel gas. And that is where we would find the ovaries on transabdominal view. To get the best look at the ovaries, though, we are always going to use a transvaginal view. Here again is another example of where the ovaries will lie in comparison to the uterus. Oftentimes they will be posterior, and the ovaries can move in their location, especially after a woman has given childbirth. So let's talk about endovaginal scanning. The main thing is to be ready to do the scan at the time of the pelvic exam. So have your machine all ready to go, have ultrasound gel on the interior of the endovaginal probe cover or condom, and SurgiLoop can be used on the exterior portion of the cover. An empty bladder is best, and you will insert the probe into the introitus, stop, and look up at the screen. Continue looking at the screen for the remainder of the exam to keep the cervix in view. Once we pause at the insertion at the introitus, identifying the cervix, we identify the cervix usually posterior, and then we fan from the patient's right to left to see the uterus. Once we identify the endometrium, we follow that stripe anterior to the fundus and identify the bladder as an anechoic structure. We then can identify the uterus as anteroverted or retroverted. So this is an example of the sweep that we take through the uterus when we have a sagittal view. Our marker dot is anterior, and the left side of the screen represents the anterior abdomen. This is an anteroverted uterus with an empty bladder, and we can see that the bladder normally would be cupped over by the uterus, bending forward, and what we would see on the left side of the screen would be anterior structures, and on the right side of the screen would be posterior structures or the cervix. So this is what we would see in a still view. We would see cervix posteriorly, bladder anteriorly. We would follow the cervix out to the fundus of the uterus by watching the stripe of the endometrium. And relative to surrounding bowel, the uterus and the ovaries will look hypoechoic because the bowel is a gas-filled structure. This is an example of a sagittal view of a retroverted uterus. So now we see the cervix anterior and the uterine stripe coming posterior, and so we know that this uterus is tilted backwards, or it's a retroverted uterus. This is another example of a retroverted uterus. So the bladder would be anterior here. The cervix is anterior here, and we follow out the endometrial stripe, and we can see this uterus so well tipped all the way backwards because there is a large amount of free fluid surrounding the uterus. And then we can also see bowel peristalsing here. So let's talk a little bit more about the endometrium. We will measure the echogenic area in the thickest plane in a sagittal view. In a normal menstrual phase, it will be 2 to 4 millimeters or quite thin. The proliferative phase is trilaminar in appearance, and it can be 5 to 11 millimeters. In the final phases, or secretory phase, it is uniformly thick. It's 7 to 16 millimeters. If it's more than 5 millimeters in a postmenopausal woman, this should set off an alarm in your head to have this patient get an endometrial biopsy for cancer. The myometrium should be uniformly hypoechoic, except for we will notice the anechoic arcuate vessels around the edges, and we can put color flow on those to confirm their vascular nature. Here's an example of the trilaminar shape of the endometrium. And this creepily reminds me of this guy's lips, doesn't it? Here is what an endometrium would look like if you have a foreign body or an IUD in it. You will see reverberation. This is important to recognize because a lot of times women will come in with pelvic pain or bleeding with an IUD, and you want to make sure it's in the endometrium and it hasn't migrated somewhere else. This is where the myometrium is in the uterus, and the red outlines the arcuate vessels. The myometrium, again, should be uniformly, relatively hypoechoic. This is what an abnormal myometrium looks like, and here we see a calcified fibroid giving off shadow in the myometrium. This is another example of what a fibroid can look like. So they can be calcified or they can be heterogeneous mixture in the myometrium. And we also see a baby here with a heartbeat. So this is bladder anteriorly. So for the cervix, usually the cervix is posterior, and usually it's the most posterior structure, and we can follow it anterior to find the fundus of the uterus. Almost always we will see hypoechoic Nabothian cysts in the cervix, and that is normal. We can measure cervical length in the second trimester of pregnancy, and we really want to see it at least 3 centimeters to know that we don't have cervical insufficiency. Here is a sagittal view of the cervix right in here. And we see a small amount of posterior free fluid in here. So coronal views, transvaginal, we will get very good at these. We start sagittal at the level of the endometrium. We place the fundus in the middle of the screen and slowly rotate our probe 90 degrees counterclockwise, so our marker dot ends up on the patient's right. Once we have the marker dot on the patient's right, we fan the probe anterior to posterior very slowly. We identify the ovaries by following the corneal flare out laterally and moving our probe in a centimeter deeper. So this is a coronal view of the uterus. This is the bladder anterior, and we can follow out the corneal flare of the uterus to find the ovary. And this is an example of a corpus luteal cyst after ovulation in an ovary, which is otherwise normal. So for the coronal view, our marker dot is right, and this is the view I like to find the ovaries in. The right side of the screen is left-sided structures. And when I look for the ovaries, I move my probe a centimeter deeper and a little bit lateral to the uterus. Just below this ovary here, we see an anechoic structure, which is the internal iliac vein and artery in the anatomic location that we will usually find it. We will see multiple follicles in the ovaries, and some people say they look like a chocolate chip cookie. All I know is you really have to train your eye for a hypoechoic structure. And here we see pieces of the internal iliac vein and artery. This is actually a very interesting patient I saw. I was looking for the ovaries, and what I saw was fundus with endometrial stripe and fundus with endometrial stripe and an ovary in between. So this is in essence a ovary sandwich formed by a bicornuate uterus with the ovary sandwiched in between. So more about the ovaries. Normal ovaries are 4 by 3 by 2 centimeters. They lie about 1 centimeter anterior and medial to the internal iliac artery and vein. So if we cannot find them, we look for the internal iliac artery and vein and move our probe a centimeter anterior and a centimeter medial. The ovaries are moderately echogenic and contained within the lateral edge of the broad ligament. They will have scattered 3 to 6 millimeter small antral follicles, encyclical larger dominant Graafian follicles which mature at 18 to 24 millimeters. And this is an example of an ovary right here. And you can see the iliac vein and artery right here. So finding the ovaries can be tricky when you're first learning, but you will get good at it if you do enough of these scans. The first trick is to follow the cornua of the uterus laterally. Train your eye for a relatively hypoechoic area. The other thing you can do is just know that the ovaries are 1 centimeter anterior and 1 centimeter medial to the internal iliac artery and vein. If you can't find them on the coronal view, go sagittal and look posterior to the uterus. Once you find one ovary, go in the exact same AP plane slowly across the uterus to find the other ovary. And here again, we see that example of a corpus luteal cyst, and that left ovary will tend to hug the uterus a lot tighter than the right ovary. This is another example of an ovary here. We followed out the corneal flare. And here's a more posterior ovary seen in a sagittal view of the uterus. And we can see a tiny, tiny bit of free fluid right there, which is physiologic. This is an example of a thickened endometrial stripe here. And we see a bunch of free fluid on both sides of the uterus. And we also see a piece of an ovary right there. So this person probably had a ruptured ovarian cyst. Here we see a cyst that has not ruptured yet and was causing pain in the pelvis. And this is when we really want to check the flow, especially if an ovary is more than 5 centimeters and the cyst is very big. That's more likely to cause torsion. This is what a hemorrhagic ovarian cyst looks like. And this again is another example of a hemorrhagic ovarian cyst. This is an example of another ovary bathed in free fluid and probably a ruptured ovarian cyst. Now we're going to talk about pregnancy, and most pregnancies are not triplets like this one, but we will go on to talk about certain things that you should look for. So, when do we know for sure that a woman has an intrauterine pregnancy? The gold standard of intrauterine pregnancy is cardiac activity seen in the endometrium. This can be seen by 41 to 43 menstrual days or 6 to 7 weeks after the beginning of the last menstrual period. We should see cardiac activity if the crown rump length is more than 5 millimeters, and we should also see cardiac activity if the gestational sac is more than 15 millimeters. The double ring sign is if you have a yolk sac within a gestational sac. And we should really see that yolk sac if the gestational sac is greater than 1 centimeter. If we have a beta more than 1250 to 1500, we should be seeing a gestational sac. So the earliest signs of pregnancy and their correlation to a beta HCG is a gestational sac at 5 weeks should have a beta of about 1,000 to 2,000. We should see a yolk sac at 6 weeks, and the beta HCG should be greater than 2,000. 6 to 6.5 weeks, we should see cardiac activity, and the beta at that point will be greater than 10,000, and the gestational sac will be greater than 15 millimeters. Transabdominally, all of these findings are at least 1 week later. So just to review what we sort of expect our beta HCG levels to be at 4 weeks, they should be about 90. At 5 weeks, they should be about 2,600. And at 6 weeks, they start to become extremely variable, 4,000 to 100,000. We expect the beta HCG to go up by 66% every 48 hours. And we expect a plateau to occur when the placenta starts growing, which is at about 12 weeks. So this is one of the first signs that make us feel secure that we have a intrauterine pregnancy, and this is the double decidual sign. It's actually only seen in half of all pregnancies, but what we want to see in a healthy pregnancy is a thick echogenic ring around the gestational sac, and the innermost layer is the decidua capsularis. The outermost layer is the decidua vera, which is slightly more hypoechoic. The endomyometrial mantle is important for distinguishing interstitial pregnancies, and this should be greater than 8 millimeters from the edge of the gestational sac to the edge of the myometrium. The yolk sac is part of the double ring sign and is also known as the balloon on a string. It should be very symmetric and circular at the edge of the gestational sac, and we should see it before 6 weeks, and if the gestational sac is more than a centimeter. Again, the beta will be somewhere around 1250 to 1500. And this is an example of the balloon on a string. And here we see fetus, here we see the balloon on a string. And you can actually see the decidua capsularis and the decidua vera very well in this example. This is a corpus luteal cyst, which is what makes women feel so nauseated and also sustains the pregnancy and creates the HCG rises during early pregnancy. So let's talk about dating and pregnancy. The most accurate method of dating in pregnancy is that crown rump length in the first trimester, and we measure from the top of the head to the bottom of the butt. Second and third trimester dating, we can do the biparietal diameter, which is the most accurate of all of them during the second trimester. And we measure the outer cortex anterior to the inner cortex posterior. We measure at the level of the thalami. Femur length, we just measure at the longest points. And abdominal circumference, we measure at the level of the stomach. Here's an example of the biparietal diameter, and we're looking for this arrow sign, which is the coming together of the third ventricle and the quadrigeminal cistern at the level of the occiput, and then we look for the paired lakes of the thalami. We're going to measure from the outer skull anterior to the inner skull posterior. This is an example of a measurement of the femur length, and you're going to measure from the ossified diaphysis and metaphysis. This is an example of early fetal heart tones. They may be slow for the first week, from 6 to 7 weeks. And the way we measure fetal heart tones is we use M mode. We do not use Doppler because it has too much power. So always use M mode to look at fetal heart rate. This is a bonus gender quiz, and we are looking right here. And I think that this is a boy. And this is what a girl would look like. This is what 2 pregnancies look like hanging out together. And now we're going to talk about vaginal bleeding in early pregnancy and what we should do. So this is a very important thing that we need to do because we're going to see a lot of it. If you have bleeding in pregnancy, the first thing you want to do is get a pregnancy test and confirm the pregnancy. And next thing you want to do is always do a transvaginal ultrasound. If you have an IUP on transvaginal ultrasound and you've already done your type and screen to look for the RH typing, then the beta is really not going to help you at all. So if you have an IUP with a heartbeat, you really just need to know the blood type from there, and possibly a fingerstick hemoglobin or a hemoglobin level on a lab test. Then the patient can go on to get a formal ultrasound as an outpatient. Next, if you do the transvaginal ultrasound, you've ordered the beta, a type and screen, and the HCG, and you see clearly a lot of free fluid and an ectopic, you call OB. If they want to get the formal, they can, but I would call OB first. If you don't see a IUP or free fluid, go on to order the formal ultrasound and check the beta HCG. The beta HCG is only useful if you don't see a clear IUP. So if you see an ectopic and it's ruptured, or you have a mass greater than 4 centimeters, or you have fetal heart tones, usually these patients need to go to the operating room. Otherwise, they may try methotrexate, which does have about a 20% failure rate. So even if a patient has been treated for an ectopic and they come in with severe pain, you still need to worry that the methotrexate did not work and they have now ruptured the ectopic. Now we're going to talk about abnormal early pregnancies, including ectopic pregnancy, molar pregnancy, blighted ovum or anembryonic pregnancies, and retained products of conception. Ectopic pregnancies are quite common. They occur in 1 of every 65 pregnancies. The most common ultrasound finding is an empty uterus alone. Do not let a pseudogestational sac fool you, which may be somewhat irregular and a very tiny sac within the gestational sac. And always measure the endomyometrial mantle. Again, we want it to be greater than 8 millimeters. So if you have a woman come in shock, get the urine by cath if you need to. Presume the diagnosis is ruptured ectopic until proven otherwise. You will have a 10% incidence in symptomatic women. This rate has increased times 4 in the past 20 years. The urine HCG is very sensitive. It detects levels of about 11 to 16 at about 3 weeks after the beginning of the last period. Transvaginal ultrasound will be diagnostic in 75% of patients at presentation. Of these patients, 15 to 20% will have a live ectopic. And even at very low beta HCG levels, less than 1,000, our transvaginal ultrasound will be diagnostic in 50%. 40% of all ectopics present with very low HCGs, less than 1,000. Of those, 40% will be ruptured, and 15 to 20% will have a live ectopic. So even if you have a low HCG, do a transvaginal ultrasound because it may still be diagnostic. Non-specific signs of ectopic include free fluid in the pelvis, which gives you over a 50% chance of having an ectopic. If you have moderate to large free fluid, that goes up to 86%. If you do see a complex pelvic mass, that has a 75% chance of being an ectopic. Mass and free fluid gives you a 97% chance of being an ectopic. It's most likely an ectopic pregnancy. If you see a tubal ring, that is very specific. Again, you have greater than a 95% chance of this being an ectopic pregnancy. And what we'll usually see in an ectopic pregnancy is we'll see the ovary out laterally, and in between the ovary and the uterus, we will see an adnexal mass, or in this case, we will see a live ectopic with a heartbeat. So we'll see a tubal ring, and sometimes we'll see this heartbeat 15 to 20% of the time. Oftentimes we will see a ring of fire or inflammation around the tubal ring. This is another example of a tubal ring and an ectopic pregnancy. And here is an example of a ruptured ectopic. And here again, we can see the uterus and the tubal ring and lots of free fluid surrounding the ovaries and the uterus. And here again is that tubal ring. This is another example of an ectopic pregnancy with a heartbeat. Heterotopic pregnancy has an incidence of 1 in 8,000. There is a 1% incidence in IVF patients. If you see an IUP, but there is free fluid in the pelvis and the patient has adnexal pain, consider heterotopic on your diagnosis. Subchorionic hemorrhage is a common cause of bleeding in early pregnancy. In itself, it does not increase the miscarriage rate compared to other things that cause bleeding in pregnancy. And what you'll see is blood surrounding the gestational sac. If you see an irregular gestational sac, that is a warning sign that this may be intrauterine fetal demise, especially if you've lost your echogenic ring around the gestational sac. A blighted ovum is any sac that's greater than 2 centimeters without a visible fetus. You will lose again that bright echogenic ring of the chorionic sac. And the problem with these blighted ovums is sometimes the beta will continue to go up slowly or sometimes double normally for a little while. It's very important after a blighted ovum is treated that the HCG goes all the way down to 0. A molar pregnancy has a very high HCG associated with it, and therefore the women have a lot of nausea and vomiting. It's considered a snowstorm appearance of the uterus and occurs in 1 in 1,500 to 1 in 2,000 pregnancies. And occasionally, especially if a patient has a history of molar pregnancies, they are more likely to have them in the future. And up to 1/3 of these can look like a blighted ovum. And this is another example. It's a cluster of grapes or snowstorm appearance of the endometrium. Abnormal second trimester problems include placenta previa, which is usually painless, bright red bleeding. This is easy to diagnose on ultrasound. We expect the placenta to be 3 centimeters away from the cervical os or it's considered a marginal previa. It's very common in the second trimester, and it's normal up to 28 weeks. You may have a false positive if the bladder is full. Placental abruption presents with painful, darker bleeding, oftentimes after trauma. Retroplacental hemorrhage of as little as 60 cc's has a 50% fetal mortality. Ultrasound is not as good for diagnosing this. Here's an example of previa. Again, it happens in 1 in 200 pregnancies late in pregnancy, but what you will see is the os will be covered up by the edge of the placenta. It will present with painless, bright red bleeding on exam. The placenta will be overlying the cervix, and ultrasound will be able to see this consistently. Abruption, ultrasound sensitivity is not very good. The negative predictive value is only 14%, and we will see it in 25 to 57% of the time. If we do see it, such as this ultrasound, it is very specific. This is a postpartum woman who comes in with bleeding, and what we notice is she has a large amount of flow in the endometrium. And we know that this means it's retained products of conception because it has blood flow there. If it was just clot and postpartum bleeding, she should not have flow. Other abnormal findings on ultrasound we will cover today are dermoid cysts, endometrial cancer, and tubo-ovarian abscess. So these are problems in the pelvis, and let's take a look at these. This is a postpartum female with an endometrium much thicker than 5 millimeters, and it's very echogenic, and so this always raises our alarms for endometrial cancer, and this is what she turned out to have. This is what a dermoid cyst looks like. It's very homogeneous. It's very large. Oftentimes there's a small amount of free fluid surrounding it. This is a dermoid cyst. This is a woman who came in after her honeymoon, and here is her uterus. You can see the endometrium right here, and behind her uterus we see these hypoechoic areas, and even lateral over here we saw a hypoechoic area of mixed heterogeneity, and this woman turned out to have tubo-ovarian abscess. The important thing about tubo-ovarian abscesses that I've noticed is when you do an ultrasound, you don't seem to find it on just one adnexa. Oftentimes you will find some of this infection behind the uterus, and oftentimes you'll find it on both sides, and this makes sense. If an infection is going to get so bad that it goes through the uterus and out to the surrounding areas, it's not just going to go to one side. This is another example of a TOA, and this requires admission and IV antibiotics. This is a septated TOA. Any questions? Thank you for your time, and just remember to do as many of these exams as possible. Incorporate it into your practice very early on so that you are very good at it by the time you graduate. Thank you so much.